A very good evening, everyone. A very good evening to all my dear students, right? And it is such a pleasure to be able to connect to you despite the pandemic that is going on. And, I'm more than excited to be associated with you today. And, we'll try and make the session a very, very productive one from my side. I'll try my best. And, something that we were really missing in the pandemic was the student connect and was the live classes that we at DAMS really stand for. And, we were thinking of various ways on how to connect with our chota and our bada bachas. And to keep this two-way communication going, we have done various measures in the pandemic itself. And then came the great opportunity of MedNeet. So I'm really thankful to Calicut Medical College for organizing such an event and giving us an opportunity to connect with all of you today, right? And yesterday we had a seminar on COVID, and I'm sure you enjoyed it. There is a video that I've done on COVID and pregnancy as well. We will be updating that as well for all of you. And it is the photo that you were seeing in the beginning is what is the DAMS DVT, which we do every year. And as you could see, it is a mega event. And this year, the pandemic is somehow trying to stop us from doing our best. But no, we would not stop. Yes. And we all are medicos. We all are known for our personalities where we strive despite all hardships. Yes, so this year as well, we are planning the DVT, which is going to be a completely new makeup of DVT, and we will conduct it at a grand level as well. So, we look forward to the DAMS visual treat, and we will bring something which is really going to be a treat for all of you, right? And in today's session, we thought of, again, trying to bring out something different for you from what we have been routinely doing. And, whenever we talk to these students, often, especially the ones who are going to appear for the exams, and especially when, you hear about the changes coming up, like next, the curriculum being changed for the undergraduate students, most of the students do feel a little scared as well. So we thought, let's make you get out of the scare. And what is the best way to, to beat your fears is to meet your fear. Right? So I thought that something that is really fearing the students these days is the change in the pattern that we are seeing, or change in the approach to medical education. And that's why I thought, let me try and ensure that, when you face this fear of yours, you are actually going to beat it as well. So that's what I'm going to try and do today. I'm going to try and beat your fear of the new pattern of exams and give you a good insight on how you can actually go and become a warrior there as well. So let's start on that note on what really are we going to expect in today's session. And as I said, I've planned something different for you, giving you a holistic approach on the changing pattern of the exams, right? Which will be useful for you, both your academics, your professional exams, when you see your patients, as well as when you go for your entrance exams, right? So I'm very excited now, and let's start off. So are you all ready? Yes, do we start off? Okay, so let's start. And, the first thing that I would want to say is that most of the times, these government organizations, they do keep changing the pattern of the exams, and which itself creates a lot of fear, right? And I would want to say something here, that exam process in India is very fast evolving these days, right? So it's evolving very fast, it is changing. And that is why, you have to understand that you have to change as well. You have to change your approach to these exams. And in order to do that, you should know what is likely to come. What is the expected scenarios? What are the things that you're going to face? And, as Charles Darwin once said, that it's not the strongest species that survive. It is neither the most intelligent ones, but the ones who respond to change. Yes, so I want to ensure that all the bachas who are associated with me are also able to see the change that is coming up, and they are going to get ready for it so that they're no longer scared. You have to be very confident, and you have to know that you are the best. Exam patterns cannot defeat you, right? So today we'll have a good insight on how we are going to respond to the change and what is required for you at your level. Now, when we look at the exam pattern, the exams, I'm sure you have heard from your seniors, your super seniors, that, the exams that are currently being held were on a very, very factual note. But since last year, we are seeing a drastic change in the exam pattern. Yes, we are moving away from factual information and we are moving towards more of comprehension and analysis-based questions, which means you need to know a good amount of your theory. But more importantly, simply knowing the theory wouldn't help unless you really understand how you will apply it, right? So that's what is comprehension. And then when we give you a lot of facts together, how would you go about analyzing it, right? So it's like problem solving. And that is what doctors are always going to be ready for, problem solving. So today we will learn how we shift our brain from the factual information to a more of a comprehension and an analysis based, way of approaching the questions. Now, the buzzword or the new buzzword that we are hearing as far as the new pattern is concerned is what is clinical vignettes. Yes. So this is what my today's target is going to be. I have to teach you the approach to these clinical vignettes. And once you learn it, you will understand that, it's actually very exciting to go through these set of questions because they give you real case scenarios, patients. And, eventually at the end of it, you feel that you are able to see a patient all by yourself. You know how to proceed when you see that patient in an emergency or an outpatient setting or in a ward setting. And you know what set of investigations to order, how to keep a differential, and how to move on to making a diagnosis, right? So the buzzword is actually clinical vignettes. And this is what we are going to stress on today, on how to approach these clinical vignettes by taking obs and gynae as a core example. So yes, I will be teaching you a good amount of obs and gynae today, but I will want to really teach you the approach to these clinical vignettes so that when you face them in the exam, you're not really scared of them, right? Now, when you come to clinical vignettes, what are the things that come to your mind instantly? They are also the key skills, right? So they're also going to be the key skills. For example, you as students, first of all, you get scared when you have a mere sight of an MCQ or a question, which is a long STEM case scenario. Yes, and this is what has really happened with a lot of students this year in the NEETPG exam. They had to really suffer time management because, these long STEM questions take a lot of time to go through it. Then, you want to see the options. You want to again go through those questions. And the resultant problem is that so many of the students could not really complete the paper itself, right? And that is one of the chief complaints of the students once they come out of the examination hall, that I knew it, but unfortunately, I couldn't really see the last 20 questions or the last 10 questions, and which is quite a setback, right? So we have to learn how we are going to read the questions fast, how we will use the audio and the visual aids that are given to us in the question, how we will integrate these videos and visuals with the MCQ, approach it, and ensure that we are reading or reaching the right answer. Time management, as I said, is super important. So I will tell you how to do that as well. And yes, the very important thing, when we give you a long question in the exam or a case scenario, which has like 6-7 lines full of information for you, the art that you have to learn is the art of picking up keywords. So you have to learn how to do the keyword analysis. One component of which is, yes, knowing your theory content well. So, when you prepare for exams, it has 3 components, bache. The first component, beta, is knowing the content. Yes, you have to have a good idea in depth of your content. The second is revision. And the third is the skill of appearing in the exam, especially when the exam pattern is changing. So yes, Knowing the content is obviously the chief thing, which is what you all are doing as well, right? You're constantly doing hard work to know that theory content, but a lot of you actually lack the application or integration or time management. So this is what I'm really going to stress on while I'm teaching you obstetrics and gynae. Yes? So now, whenever you get a big case scenario, you have to really imagine yourself being there with the patient. So whether it is a ward scenario or it's an emergency department, you have to train your brain accordingly. You have to presume you are there, because that gives you a good idea on what to do and what not to do. Because things that you would be doing in an OPD is going to be very different from things how you will proceed in an emergency setting, and is going to be different from your algorithm for a patient who's admitted in your ward. So always when you see those case scenarios, you have to presume that you are there with the patient in that environment. It gives you the good, I would say, it gives you a rush on how to handle such a situation as well. Okay. Now, always and always these case scenarios, as I said, they have long stem or body. Yes, where they have 6-7 lines giving you a lot of information. As a student appearing for the exams, you all have to know what details you need to grasp and what details you have to avoid. Okay, unless you don't learn this, you will always find yourself short on time and on integration, right? So always in these case scenarios, the patient details are quite important. Now, what do I mean by patient details? By this, I really mean the sex of the patient, as well as the age of the patient and the scenario in which the patient is presenting. I'm going to talk about obs and gynae, so sex is pretty much settled. But here I wanted to give you a good approach, whether you get it as a medicine question or a surgery question, right? So always take care of the age of the patient. For example, if I give you an example of obs and gynae, you think of different set of problems when you have a post-menopausal woman or a perimenopausal woman, whereas you think of different set of problems when you are dealing with a patient who is in reproductive age group, right? So causes of abnormal bleeding would really be different in these two case scenarios. So, patient details are important. Sometimes they might give you race as well to identify or for you to take care of the genetic associations. But a lot of times we will usually avoid the racial component because we want you to have a holistic approach of the disease that is in question, right? But if they do give you a racial component, remember, it means you need to integrate your genetics into it, because certain diseases are more prone in certain genetic, scenarios or racial pattern distribution, right? Also take care of the chief symptoms. Always, there will be a lot of stuff written there. The patient has this, the patient has that, the pain is this. There will be so much of description about the pain. It's very similar to when you are really sitting in an OPD or an emergency setting. And that's the skill you need. You have to quickly grasp or grab what is the chief complaint. And by that itself, you should be able to make out the differential diagnosis, right? So before you go into too many details of the patient, avoiding the unnecessary history that's written there, always take a note of the chief complaint and the chief symptom. There will always be a lot of things written in these long stem questions. Not everything is important. So you have to be smart enough to know what to exactly avoid and what to highlight to your brain, right? So chief complaint, just one word of it. It could be some pain in the right lower quadrant. That's it. Then we will go on to more things, right? And similarly, look out for any signs that they have typically described for you as a highlighter or a keyword for you, right? Not everything in the symptoms would be irrelevant or signs would be relevant. There will be a lot of normal findings as well. So you have to quickly grasp on how to identify the key things, the key complaint, the key sign, the patient characteristics, age of the patient, right? So these are the informations that you're going to grasp. Now, once you have a fair idea, by doing this, you know what the question is really talking about. But now comes people who are smart enough, who know how to handle the situation. most of you would be able to make out what the question is talking about. Because, you know, the new pattern questions in NEET or next, which is proposed to happen very soon, right, is going to test you, as I said, more of your comprehension and analysis aspect, right? So a lot of times, Beta G, they will actually give you the diagnosis. So when you're really wasting your time reading that long question to make a diagnosis, by the time you'll reach to the 5th line, you realize the question actually gave you the diagnosis. So, you know, you have to learn the art of comprehension and analysis to really figure out what you're expected. So now once you have a fair idea on the various components of these long stem cases, we are going to now take examples, okay, on what to do. Similarly, the question would also give you a set of laboratory investigations, maybe some radiological investigations, and you will have to integrate them. These could be in the form of visuals as well, which I will take as a, as an example also. Now, how to approach the visuals? Yes, we will see that, you don't have to hurry yourself seeing the visual. You have to understand the visual may become very, very simple once you go through the options in the question, right? So before you actually jump onto the visual, go through the options in the question. And that will give you a fair idea on what exactly the visual really is about, okay? Now we are going to integrate all these things in the question also very soon. Also, when you look at these long stem questions, the last line is super, super important. It gives you what you really have to do, okay? So we are going to think smart and we are going to think reverse. We will always start these long stem clinical case scenarios by reading the last line. So the algorithm that I want you to follow for these long stem clinical vignettes is first read the last line, okay? Always, you do that first. Read the last line. Then see the options, okay? So read the last line, then jump to the options. You will already know what you are going to, or what the question is talking about. And then you go on to the visual. So the last line, then the options, then the visual, and in fact, the last comes the body or the stem of the question, which means I really don't want you to go through the big 6-7 lines to waste your time to get confused. I want you to read, whenever it's a long clinical vignette, I want you to read the last line first, okay? Go on to the options after that, and then see if there is any visual provided. And last, in the last Beta G, go back to the body or the stem of the question to pick up the key words. Okay, are you with me on this? Yes, have you got the algorithm or approach to these long stem clinical questions? If you have got the approach, we will now start doing these with the same approach, and you will see how things actually become simpler, how you will manage your time in a much, much better way, which is very, very important, taking into consideration, as I said, this year's NEET as well as the next pattern. Okay. So now, let us apply whatever we have learned so far into real clinical, long stem clinical vignettes. I have brought different case scenarios for you. So these are going to be 4 case scenarios which give you the different types of clinical vignettes that you are expected to get in your exams. And if you really understand these 4, I'm sure you will be able to apply them in any other subject, be it medicine, be it surgery. The approach will remain the same, bache. Okay? Now, you're all going to follow what I'm going to ask you to do, because I have to deliver the art to you. I am here today to give this art of solving the clinical vignettes to you. I have to pass it on. Yes? So you will follow what I am asking you to do, and you will realize by the end of the session, you're much more smarter. I know you're very bright people, there is no doubt, but I want you to work smart as well when it comes to competitive exams, right? So let's look at the first question that I have brought for you. Okay, so 1, 2, 3, 4, 5, 6. I want you to quickly see the question. It has 6 lines. Then there are long, long options written. Yes. Does the MCQ scare you? Yes, by looking at it. Does it look like, oh God, this is going to take a lot of time? It is something to do with the procedure as well in obstetrics, right? So you immediately, your first response is, oh, this is a long question and I have to do it quickly. You know, you already start getting panicked in the exam and you start taking even more time. So do you see how long this question is? I don't want you to read it. Let's stop reading it the way you do it. Because the way you will read, you will start like this. A 22-year-old woman is brought to emergency department with severe abdominal pain. Yes, that's how you are going to read it. And you will spend good 3 minutes, 4 minutes time just reading the question itself. Or maybe if you spend lesser time, doing the questions. Now, this is what I want you to read the question with me. Okay, so let's do this now. How to read the question written, it is a long clinical vignette. Let's see this. Okay, we have to learn the art. So I said we will first learn the last line or read the last line. Yes, so the last line is, through which of the following structures does the needle to be inserted to perform chaldosynthesis? Yes, so this is the last line. Through which structure do you need to push the needle to perform chaldosynthesis? Right, so we read the last line. Then we read the 4 options. Yes, the option 1 is through the perineal body into the vesico-uterine space. The second is through the posterior fornix into the recto-uterine pouch. Then through the anterior fornix into the endocervical canal, and through the introitus into the vestibular gland. So that's what I said. You read the last line, then you will read the 4 options, and then we will go back to the stem. Now, in this question, this is a very tricky question, in the way that the first 4 lines were just given so that you waste your time. If you realize to answer this question, do you need the first 4 lines? Now, quickly tell me, do you need the first 4 lines? The 4 lines which say, the patient comes to us, right, into the emergency department complaining of severe abdominal pain. We have given you the lab investigations. The WBC is elevated. Her UPT is positive. And we are doing a chaldosynthesis to look for blood in pelvis for a ruptured ectopic. Do you see that the question is already giving you a diagnosis? If you start reading from the beginning, you would first make a diagnosis. Then you start thinking of something else, which means you're wasting our time. So do you realize that the first 4 lines were not at all required to actually answer this MCQ? They were given to identify who are the smarter ones, who are the people who know how to conserve time and do these questions, which is actually a very easy question. What do you need to know for this question? Only 2 things, right? Chaldosynthesis is done to collect blood from the recto-uterine pouch, which is actually nothing but the other name of pouch of Douglas. Yes, pouch of Douglas. So you have to know that recto-uterine pouch is just the other name for pouch of Douglas, right? Why do we see for collection of blood in this part of the female pelvis? Let's see this. So, the pouch of Douglas is actually the most dependent part in the female pelvis. So whenever there is an intraperitoneal bleed, this is where the blood is first going to collect, right? So to make an early diagnosis of ruptured ectopic, we would want to take out the sample from this part. Yes. So as you can see in the picture, we are going through the posterior vaginal wall. Okay. And which part of the posterior vaginal wall? Posterior fornix, right? Posterior fornix. So when you pierce the posterior fornix, you are directly entering the pouch of Douglas or entering the recto-uterine pouch. And all you have to do is do an aspiration. If you get blood which does not clot, then it tells you that there is hemoperitoneum. Yes, so it tells you that there is hemoperitoneum. And therefore, you now realize that the correct answer is through the posterior fornix into the recto-uterine pouch. Right? Now, why did I pick this one as an example? This is the first example of approach to clinical vignettes. There are 2 reasons why this question is the first example. It was an easy question, but when you see it for the first time as a long MCQ, you get scared. The reason I wanted you to see this is that you have to know that a lot of times in the long clinical cases, the stem of the MCQ will have no value. Okay, they will give you the diagnosis, but they will ask you something else. And this actually happened this year in NEET. There were a couple of questions where people just, spent their time making a diagnosis, but by the time they reached the fifth line, oh God, the diagnosis is already there, right? So you really had to work on something else. So there will be some questions where the stem is not required. So you have to be smart enough to not get trapped here and waste your time. You will not do it wrong, but you will waste your time. And then what will happen? The MCQs towards the last, you will probably not be able to reach them, right? So this is what you have to understand, okay? Now, the second reason why I took this particular question as an example is, this is what is integration, right? We have been consistently talking about that even basic sciences MCQs, so whether it is anatomy, physiology, or biochemistry, they are going to be asked integrated with clinical questions. So this is actually a question from relevant anatomy, right? When you become surgeons, you have to know the relevant surgical anatomy to, operate in the operating rooms correctly. Yes. So this is a typical example how a basic sciences question will come and it will look very, very clinical to you. So this is a typical reason why I wanted to take this MCQ as well, which is fairly easy, but to give you an idea on what we would mean when we say integration of basic sciences to clinical subjects and how I want you to approach long stem clinical questions to begin with. Yes, so the answer is B. Through the posterior fornix into the rectouterine pouch. So somebody's asked me why the bleeding is intraperitoneal. So please understand, fallopian tubes are content of the broad ligament and they are very well covered by peritoneum, right? So the broad ligament is an anterior leaf of peritoneum, a posterior leaf of peritoneum, and the tube is in between the two leaves. So it is a content of the broad ligament, right? So whenever there's going to be bleeding, the bleeding is intraperitoneal. All right. Now, are you ready? We are going to keep increasing the level of the MCQs as well to keep you interested and to make you understand how case scenarios can go from really easy but long stem to more difficult and more difficult. So are you ready for the next one? Yes. Are you ready for the next clinical case scenario? Okay. So let's go on to the next one. Okay, so this is again a long stem clinical question, but I don't want you to solve it right now. We will solve it together, just in the way that I have taught you to do it. Okay, so we will do it as per my algorithm, right? So the question is long stem. It still has 5 lines. It looks like a question, which will need more integration. Now there is a visual also in the MCQ. Yes, now a visual has also been provided for you in the MCQ. So are you getting scared by looking at the MCQ? Are you getting scared when you look at the question? It looks a long one with options, with a visual as well, right? Are you scared? No, we will not get scared. Yes, we will face our fears to beat it. Okay, so let's approach it the way I taught you to approach the clinical vignettes. Are you ready the way I taught you? Yes. So Dr. Deepti's approach is going to be, first read the last line. Yes, so that's what my approach is. So the question last line says, what is the best next step in managing this patient? Now, Beta Ji, this is also the new pattern of exams. The new pattern of exams is not asking you to simply identify the findings. Okay, they're not asking you to identify the findings. They're asking you to integrate different findings given in the case scenario or in the STEM. And then once you do an integration, you do an analysis, and then you answer the management part. So this is an MCQ where we are going to talk about analysis. So we will comprehend the question first. We will do an analysis of the question and then we will reach the answer, right? So the last line is, what is the best next step in the management? What is the next thing that I told you to do when you get a clinical case scenario? What was the next step in the algorithm? Go to the options. Yes, are you all ready to go to the options? Okay. Options say amnio infusion, cesarean delivery, phenylephrine, and expectant management, right? So this is a management where you have to, I think first, if you look at it, the first thing you have to identify is, do you really need to do something for the patient or you don't really need to do it? The second is, if you really have to do something for the patient, how urgent is the process? Yes, so we have to do something or we are going to just, wait and watch. That's the first thing the question wants you to identify. The second thing the question wants you to identify is, if you're going to do something, is it something which is very urgent or is it something that you can look out, wait for? Yes. So now what was the third step in the algorithm? After seeing the options, what is the third step in a visual question? What are we going to do, beta? We are going to look at the visual now. Yes. So next step was go and look at the visual. So are you all ready to look at the visual with me now? Yes. Okay. So we are going to see what the visual has for us. So this is a NST graph of a patient. Yes. So what is provided to us is the NST graph of the patient. I hope you all know that in the NST graph, at the bottom, what you see are uterine contractions. Yes. So at the bottom, what you see are uterine contractions. What is the top part of the graph? The top part of the graph is fetal heart rate, right? So the NST graph or the CTG graph, which is cardiotocography, because it is also showing you the contractions. Yes. So when we show you with contractions, it is a CTG, cardiotocography. When we show only the fetal heart rate, no contractions, then it is NST, the non-stress test. Okay. So here it is going to be contraction or cardiotocography, a CTG graph. Right. Now, what do you see in this CTG graph? Now, whenever there is a peak of the contraction, yes, at the peak of the contraction, the fetal heart rate begins to dip. Can you all appreciate that? Very good. Princey, you're absolutely right. So at the peak of the uterine contraction, the fetal heart begins to dip, right? The next thing I want you to identify, is the dip gradual or is it abrupt? Is it gradual or is it abrupt? So at the peak of the uterine contraction, the dip is starting. It is not starting with the onset of the contraction. Yes, it is starting with the what? It is starting with the peak of the contraction. Yes. What is the next thing? The next thing is that this dip is gradual. Yes, it's not abrupt, which means it is slowly falling and it is slowly going back as well. Yes, there is a slow fall and a slow pickup. Okay. And the third thing, whenever we give you an NST graph, the third thing I want you to identify is the dip persisting after the contraction has stopped? Yes. So yes, the contraction has stopped here, but the dip is persisting. Yes. So the dip is persisting for some time, even after the contraction has gone away. So what is this kind of a dip in the fetal heart rate or a deceleration? So this is a late deceleration. Let's quickly find out the 3 keywords to pick up a late deceleration. The onset of the deceleration will be at the peak of the contraction. Yes. Second, the dip will be gradual. It will not be abrupt. And third, the dip will be persisting even after the contraction has gone away, right? So this is how you define a late deceleration. Yes, so the graph is of a late deceleration, right? And now Very good. Now I want you to do the analysis. Do you realize that we did not even have to go to what? Go to the stem till now. So we already know what is the reason for the dip. Do you all remember what is the reason for type 2 or late decelerations? It is uteroplacental insufficiency. Yes, so this is a late deceleration, and the reason is uteroplacental insufficiency. So now we know that the patient is having uteroplacental insufficiency. The question is asking the management for that. What is the next thing that you have to look out for? The cause. Yes, we have to see, is there a reversible cause of this insufficiency or not? Why? If there is a reversible cause, I will treat the cause. But if there is an irreversible cause, then I will have to do a standard or a termination of pregnancy. Yes? So listen to me carefully. Once I know that there is uteroplacental insufficiency, I have to look for cause. If the cause is reversible, I will simply treat the cause and then the deceleration will go away. But if it is something that I cannot treat, then I might have to deliver the baby. Yes? So now to find out this part of the MCQ, so this is the analysis part that I am talking about. So this is a one level higher MCQ. We are talking about the analysis part now. So let's look out for these two things in the stem. Do you see the retrograde approach? So I am going to find out the cause, okay? I'm going to find out the cause of this insufficiency in the stem. Is this part clear? Are you all ready for the stem? Yes. So now to look for the cause, I'm going to look at the stem of the MCQ, okay? So look at this stem. She is a 25-year-old lady. A lot of things are written. She has a 150 beats per minute variability, beats per minute, and moderate baseline variability. She is noted to have the following finding after placement of an epidural catheter. Her BP is 90/55 and heart rate is 100. Quickly tell me, have you found out the cause? Yes? So the cause was hypotension. Yes, the cause of this deceleration is hypotension in the patient. The hypotension beta G has caused the placental insufficiency. So now quickly tell me, can you reverse the hypotension? Let's see the cause. Very good, very good. So what is the cause of hypotension? The epidural catheter. Yes, so you all know that the epidural catheter is put to look for what? For labor analgesia, for painless labor. Yes, and you all should also know that epidural can cause hypotension. Yes, do you all know this? Epidurals can cause hypotension. So quickly tell me now, you have identified the cause. Yes, is it reversible or not reversible? Let's see. Reversible or not reversible? Reversible. If I treat the hypotension, I will maintain the placental blood flow. Yes, and the uteroplacental insufficiency will go away. So, do I really need to do a cesarean section? No, this is a reversible thing that I can do. Yes, if I treat the hypotension, I will treat the uteroplacental insufficiency. Very good. I have very bright students with me. I am so happy today. Yes. So what would you want to do? So in other words, the question is asking you, which is the pressure agent of choice for hypotension in pregnancy? That was a one-liner. Yes, I am sure you all must be learning a lot of one-liners. And you think one-liners can make you win battles? No. But when you combine your knowledge or analysis of one-liners into your clinical questions, that will make you win the battle. Yes? So which is the pressure agent of choice in this patient? Phenylephrine. All I need to do is give her phenylephrine. It will reverse the hypotension of the patient and I will treat the decelerations. Do you all understand now how we go one step? Yes. Also, do you now realize that some of you were earlier answering it as cesarean delivery? ये कौन से वाले बच्चे हैं जो बहुत जल्दी करना है? देखो, you have to know in which MCQ you have to be very quick as a reflex, in which MCQ you can give little time, and in which MCQ you can give a little more time. So now do you see the algorithmic approach? So let's do it again. We did the last line first. Yes, so we did the last line first. Okay, then we went to the options. In the options, we understood that there is something which is emergency and there are some components which are non-emergency. So that's what I have to find out. I have to find out, is there an emergency or is there no emergency? Yes. Then we went on to the graph. We found out that the graph had late decelerations. Yes. The cause of late is UPI. Okay. So uteroplacental insufficiency. And then I said we will go back to the stem or the body of the MCQ to find out what is the cause. If it is a reversible cause, I will treat it. But if it is non-reversible, then I will have to deliver the baby. So here I found out that this is going to be delivery of the baby, not delivery because it's not emergency, it's a reversible cause. Yes, so the reversible factor is what? The hypotension caused by the epidural. So what do you do with the epidural? You are going to give a pressure agent. Okay, somebody was asking, madam, why did we put the epidural? Beta, to take care of labor pains. Okay, so nowadays we very well can do a painless labor, which is what is labor pain, taking care of labor pain, for which the method of choice is epidural analgesia. Okay, and remember the level of block, right? The level of block is going to be T10 for vaginal delivery. That's also important, right? And the drug of choice, okay? The drug of choice is going to be bupivacaine, right? So the drug of choice is bupivacaine. We start with 0.0625%, right? So that is the drug of choice for epidural analgesia, and the level of block is T10, okay, for vaginal delivery. No, beta ji, it is not T6, it is T10, okay, for vaginal delivery. All right, are you ready for the next level now? Yes, I said I have brought different case scenarios for you, where I want to give you a holistic approach on different forms of case presentations or clinical vignettes. The first option or example was where you do not need the stem of the question at all. It is given to you so that you waste your time. So you will not waste your time. Okay. The second option or the second case scenario was one level higher, where we had to integrate a visual, right, with the clinical vignette, right? And this algorithm that we are doing will be applicable to all subjects. That's why I said, for me today, I'm not aiming at teaching you obs and gynae. My goal was to teach you the approach so that you are going to, apply it for all other subjects as well. Okay. Okay. Somebody is asking about amnio infusion. Amnio infusion is useful for which type of decelerations? Let's understand that. Now, so you know about late decelerations. There is another category which is called as variable or type 3 decelerations, right? Now, the classic feature of type 3 or variable decelerations is, number one, they are abrupt. Okay, they are abrupt, which means there is going to be a quick fall and a quick pickup in the heart rate. So it will not be a gradual fall and a gradual pickup. Okay. Early decelerations and late decelerations are gradual. They have a gradual fall, a gradual pickup. But variable decelerations are going to be abrupt. A quick fall and a quick pickup. Okay. What is the cause of variable decelerations? Cord compression. Yes. Now, there could be many reasons for compression of the cord. One of the commonest reason for compression of the cord do you know is oligohydramnios? Yes. So when the liquor around the baby is less, right, what happens is the uterus is full of fetus, right? So then the cord can be easily compressed by the fetus or by the uterine pressure, right? So oligohydramnios is a common cause of variable decelerations. So had this picture of a graph of variable decelerations, then how would you treat it? So oligohydramnios causing variable decelerations can be treated by amnio infusion. Yes, it improves the outcome of the baby. Okay, so it improves the outcome of the baby. That is why amnio infusion was in the option. In case you do not know how to read the NST graph, then you can do that error, right? So amnio infusion is for variable decelerations. All right. So are we ready for the next case scenario, the next level? Yes, I'm going to keep increasing the level, beta G. So now we're going to get onto the third pattern of clinical vignettes or case scenarios that you can get in your exams, not just exams. These are real case scenarios. So they are going to help you when you are in your emergency wards or your outpatient departments or inpatient wards, right? So you have to presume you are the doctor in charge there and behave like a confident one who knows exactly what to do because you are the brightest of the lot. Okay, so let's go on to the next level. Now, in the next level, I have a video-based question for you. Okay, so the question has again a moderately long stem, not very long. It's about 4.5 lines. There are certain options which look pretty factual. Okay, so these options are factual, but you have to learn, as I said, to integrate facts with knowledge and analysis. So now the options are factual, but we are going to integrate them with our question. So we will do it. As I said, this is a video-based question for you, right? So there is a video-based question, but as I said, we will first see the last line. Yes? The last line of the question is, at what time this procedure is done? Okay, so we will simply follow the algorithm I have taught you. Okay, the algorithm is first see the last line. All right, the last line is, at what time this procedure is done? What is the next thing we follow after you read the last line? The next line we follow is see the options. Right? So we have certain options which are very close options. So 24 hours before injection HCG, 24 hours after injection HCG, 36 hours before injection HCG, or 36 hours after injection HCG. So these are close options. So for close options, you have to know your content well. The more you know your content, the better it is going to be for you, right? Then the third thing I said was, once you have seen the options, now go on to what? The video or the image. So are you ready for the video? Yes. So let's look at the video. Right? So the video is now with you. Let us try and see what's happening. So this is an ultrasound, if I give you a hint, of the ovary. Okay, so it is an ultrasound of the ovary. What are we doing? Can you see we are inserting something in the ovary and the size of those black things is reducing. Okay, so we are putting a needle in those black things. What are those black things? Black on ultrasound is fluid. So what are these? These are growing follicles. Yes. So these are the growing follicles, and the follicles have fluid. They have a fluid filled cavity called as antrum. Yes. So they are big follicles there. Yes. And what are we doing? We are puncturing the follicles. Why are we doing this? Are we bad people? Why are we doing this to the poor female? We are puncturing her follicles. Yes, what do you think we are doing? Now let's go back to the stem. So this is ovary. We are puncturing the follicles. The follicle size then reduces, right? Let's see the stem now, because to understand what's happening, you need to know the basic of the patient. Now you again need the stem here. So she is a 36-year-old woman who's married for 8 years, undergoing infertility treatment. So keyword, treatment for infertility. Now the other keyword, the following procedure is done during her or after her treatment with injection gonadotropins. Yes, so that is why the follicles are so big. Yes, we were giving her gonadotropins. Do you know the example? Example is HMG, okay, human menopausal gonadotropin. Or we also have recombinant preparations, yes, like recombinant injection FSH. The difference is that HMG, because it comes from the urine of post-menopausal women, is relatively cheaper. And recombinant formulations are definitely more expensive. What is the other difference? The other difference is that since the source is urine of a post-menopausal women, it will have some contaminants as well. Yes? So HMG, which is human menopausal gonadotropin, is less effective as compared to recombinant FSH, which is very, very potent. Yes? So that is the advantage of, the recombinant formulations. So we have given those to make the follicles grow. Can you tell me, if you generally think of conception or pregnancy, yes, what is the next thing that happens after follicular growth? Don't think about this case scenario. I'm trying to help you extract information from your theory. You need the depth of your theory to reach. Yes? So after the follicle is mature, what happens to the follicle? It is going to rupture. Yes? The follicle is going to rupture. But if it ruptures inside the body, my infertility treatment goes waste. I am doing a IVF here. So I want to take the ovum outside. Yes, so that I can do a what? In vitro fertilization. So I am going to take out the ovum from the patient so that I can make it fertilize in a test tube, right? So this is actually a procedure of ovum pickup, right? So this is the procedure of ovum pickup. Now, this actually reduces it to one line. Ovum pickup, or in natural circumstances, ovulation, happens how many hours after LH surge? In natural circumstances, it happens after LH surge, which is 36 hours after the LH surge. Yes, but here it is IVF, where the patient's own hormones are suppressed. So everything you have to give from outside. Now to bring about the ovulation in an IVF cycle, I need to give a trigger. Okay, so a trigger has to be given to do this rupture of the follicles. This trigger that we use is injection HCG. So do you now understand why injection HCG is in the options? Because this is the trigger we will use. Right? So this is the trigger we will use to bring about the rupture. So obviously we will follow the same protocol. The ovum pickup is done approximately 36 hours after injection HCG. Yes? Now are you able to correlate? Yes? So a lot of you will realize, if you know your basics well, if your theory content is good, and if you follow the algorithmic approach, you will half of the time not even need the video or the image. For example, in this question, some of the students were able to answer even without the video. Yes, because you know that we are talking about ovulation here, and ovulation will happen 36 hours after LH surge. Now, why HCG is used as the trigger? Do you know that in HCG, I'm sure you all know that alpha subunit, yes, alpha subunit of HCG is absolutely identical to alpha of LH, FSH, and TSH. Yes, it is absolutely identical to the alpha subunit of LH, FSH, and TSH. Now I'm going to give you the little new information which will help you in the exams. And that is the beta subunit of HCG very closely resembles, it's not identical, but it very closely resembles the beta of LH. Yes, now do you understand why HCG is used as the trigger? Very similar to LH. So the receptors are also very similar, right? So now you understand why HCG is being used as a trigger beta? Very good. I am seeing that so many of you know the correct things. That's absolutely great. And that makes me happy. So this is what you have to know about ovulation trigger in an IVF cycle and how a procedure of ovum pickup looks like. Now in the exam, even if they give you a smaller history or a bigger history, once you have seen what ovum pickup looks like, you will never forget it in your life. Yes, right? So infertility questions, some black cystic things which are decreasing in size is nothing but ovum pickup. Yes, was this clear? You want to see the video again? Okay, I will try and play the video again for you. Okay, so I'll play the video again. Focus on the black follicles. A needle is entering those follicles, and once the needle enters, the follicle begins to decrease in size. So focus, Beta Ji, focus on the black follicles. I am repeating the video for you. Yes, are you all able to appreciate how the follicle size is reducing? How we are puncturing the follicles? Yes, see, it is a beautiful video. How you keep puncturing the follicles and how they keep reducing because you're taking the ovum from them, right? So this is ovum pickup. Remember, it is an ultrasound guided procedure. Yes, it is an ultrasound guided procedure done for IVF patients, right? Where everything is given from outside, right? We want to take out the ovum because we want to fertilize it outside in the test tube. Yes, was this MCQ clear for all of you? Easy? Do you now realize that no matter how we change the formats, whether it is an integrated question to basic sciences or an integrated question to a visual or an integrated question to a video, which is what is, the new pattern for next in NEET. Yes, a transvaginal ultrasound, yes. Transvaginal ultrasound will always have a better view of the female pelvic organs because the probe is closer to these organs. Yes, so this is a transvaginal scan. Yes, wonderful. Are you ready for the next level? And I said I'm going to increase the level. Are you ready for the next level? The next level is again a specially crafted MCQ for you. I have brought it specially for today's session because this is a common complaint or a problem faced by the students in the real exams, that the MCQ starts from one subject, but it goes on to another subject or a third subject as well, which is the idea of vertical and horizontal integration. Yes, and then that means the student has to know not only obstetrics or not only gynecology, they would have to know medicine as well. They will have to know surgery as well. And they will have to integrate these subjects in a female patient also, right? A female patient does not necessarily mean it is going to be an obs and gynae problem. Yes? Okay, so we are going to go on to the next question, but somebody was asking me about HMG अनिकेत, HMG का फुल फॉर्म है ह्यूमन मेनोपॉजल गोनाडोट्रोपिन. The reason I want you to know the full form because it gives you the answers on its own. It is gonadotropin, which means it will have LH and FSH, and it is coming from urine of postmenopausal women. Okay, why? Because the postmenopausal women have very high levels of FSH in their body, also in their urine, and urine is a natural source. So when we had to first make gonadotropins, we used a natural source that kept the cost low, right? So injection HMG has 75 international units of both LH and FSH bache, right? So it is available as an injection format and popularly called as HMG. But nowadays, as I said, more potent ones are being used, which are recombinant formulations, okay? Yes, so I will tell you what is vertical and horizontal integration, Ashwarya. The first MCQ that we did, beta, okay, which was anatomy in obs and gynae, is vertical integration. When the professional year changes, that is vertical integration. But when the professional year remains same, so medicine and surgery integrated, surgery and medicine integrated is what is horizontal integration. So now I'm going to give you a question on horizontal integration because we have already done one question on vertical integration. These are the terminologies used by the government of India when they were planning next. So this is what is the next pattern of the exams: horizontal and vertical integration. Questions based on concepts and analysis, right? And less of factual things, but yes, factual things are still required to do the integration. They act like threads, joining the things together. Okay, so now are you ready for the next level? Okay, I have a bright batch of people with me. That makes me very excited. So I'm going to go on to the next level. So now we have a long MCQ. It has 1, 2, 3, 4, 5, 6, 7 lines. Yes, so the next question has 7 lines with us. All right, and it starts with the patient being a pregnant woman who is 30 weeks pregnant, right? So a very long MCQ where I see a lot of things are given in her symptoms. I see a lot of examination findings being given, but we will not waste time on any of this. You are all my bachas and you are going to learn with me the trick of the approach. Never forget the algorithm. What is the algorithm that we did? The last line comes first. Too scary. Let's remove the scare factor from it. Remove everything. Everything washes away and my eyes are going to focus, beta G, only on the last line. Yes? So the last line is next best step. Very important. So whether it is AIMS or this year JIPMER exam or this 2020 NEETPG exam, there were a lot of questions where they've been asking you the next step, right? So where they're asking you the next step. What is the next thing that we do? Once we read the line, we are going to read the options. Yes, so we're going to read the options now. So we see that the options go something like CBC, ABG analysis, D-dimer, Doppler. So do you realize that you don't even have to read the stem? Do you think from the options itself, you are getting a clue what the MCQ might be talking about or what the clinical vignette may be talking about? Yes? Yes? So what do you think would be the clinical vignette talking about? So when you go the retro approach, especially for long clinical vignettes, we are talking about probably a case of pulmonary embolism. Yes, ABG, D-dimer, Doppler ultrasound legs. Yes, do you realize that we are going to probably talk about pulmonary embolism? Yes. So do you realize without wasting your time in reading that long stem and making a diagnosis, do you realize that just by doing this approach, you already have a provisional diagnosis? Yes. So don't waste your time. Let's go on. I already have a diagnosis now, a provisional for me now. So now let's go back to the stem, right? Let's go back to the stem of the MCQ. So your patient is 30 weeks and she's presenting in the emergency. So yes, emergency complaint, very likely to be pulmonary embolism. That is something, yes, so I'm thinking in the right lines. I'm thinking in the right lines. Pulmonary embolism was my provisional diagnosis and will present in emergency with what complaints? Yes, so the patient has shortness of breath, which is sudden onset. What else does she have after that? She also has chest pain or deep breathing. Are these features of pulmonary embolism? Yes, right? There's going to be this pain, pleuritic pain is there, right? And there is a sudden onset of breathlessness, right? What is the triggering event? What is the triggering event? So if I highlight the keywords for you, right? The patient has presented to us in the emergency. Complaint is, I told you, just focus on the chief complaint. The chief complaint is shortness of breath, which is associated with her chest pain on deep breathing. What is the next key thing here? Can you tell me? Next keyword. I always tell my students to identify keywords and put them together. Oxygen saturation. Yes, Pache? She has an oxygen saturation of 89%. Right? And, you know, we have done the examination as well. Now, do you think we are thinking in right lines? Is this probably a case of pulmonary embolism? Yes. What is the triggering event? The long drive. You should all know that pregnancy is a hypercoagulable state. Yes? So pregnancy is a hypercoagulable state, right? And as a result of which the long drive has precipitated the event. Next keyword. Yes, the chest X-ray is normal, very important because those little things can change answers. So now we have all the keywords with us, right? So keywords are a sudden onset shortness of breath, a low oxygen saturation, and a normal X-ray. Finally, I need only these three keywords, right? So, sudden onset of shortness of breath, a low oxygen saturation, and a normal X-ray. Yes, our provisional diagnosis is pulmonary embolism. Now, I have to confirm that I am dealing with pulmonary embolism because it is an emergency situation and I have to start the treatment. Which means from medicine, you have to know how you evaluate pulmonary embolism. But what is the integration here? Because if you know the medicine part, yes, if you know the medicine part, you will answer it as D-dimer. Yes, if you know your pulmonary embolism from medicine, you will answer this question as D-dimer. But ouch! Remember, this is a integration question. Integration of obstetrics or gynecology with medicine. Your patient is also pregnant. So do not forget that. That was the key word as well. She is a pregnant patient. And then if you only know medicine but don't know obstetrics, you will go wrong. D-dimer is an incorrect answer. Why? Who is going to tell me why D-dimer is an incorrect answer? D-dimer has no value in pregnancy. Neither it is sensitive nor it is specific. But why? Because D-dimer is physiologically raised in pregnancy, right? So D-dimer is physiologically raised in pregnancy. Okay. And what else? What else? So why is it raised? So in pregnancy, the net effect is a hypercoagulable state, but there is an upregulation of both the things, coagulation and fibrinolysis as well. So you do see fibrin degradation products in pregnancy as well. but the net effect is a hypercoagulable state, right? So D dimers are physiologically raised and are a useless test for pulmonary embolism in pregnancy. Now, again, let's go back. If you know your medicine well, you think yourself as a good physicist or an internal medicine person, and you know your medicine very well, what would be your next answer? Your next answer would be ABG analysis. Your next answer would be ABG analysis, which is again wrong. Which is again wrong. Tell me why. Tell me why. Because in pregnancy, if you do a ABG analysis, you will physiologically get what? Respiratory alkalosis, which means to answer this question, you have to know a chapter called as Physiological Changes in Pregnancy. Very, very important, because it is asked in an applied format, right? So pregnancy is a condition of respiratory alkalosis. So if you do an ABG analysis, again, it is going to be non-specific, right? So knowing your medicine will still not help you answer the MCQ. So now comes, how do we approach this? So please understand, always when you think of pulmonary embolism, and if someone has identified the thing here, do you realize we'd also written that limbs show edema? Yes, bilateral lower limbs show edema. Do you think before going all to big investigations, you should do an examination of the limbs? And yes, doing a Doppler is important here. Yes, so the answer here is actually Doppler ultrasound of the legs. Okay, it is Doppler ultrasound of the legs, right? I know that you know that edema can be physiological, but in this patient, we cannot ignore. She is a woman who is presenting to us with pulmonary embolism. I cannot simply say, oh, the edema is physiological. Okay, so the answer here is Doppler ultrasound of the legs. Is this clear to everybody? Why Doppler is the preferred first thing? Yes, because number one, bache, Doppler is non-invasive. There is no radiation exposure to the mother or to the baby. It is absolutely safe. Third, readily available in all hospitals. Doppler ultrasounds are readily available. So definitely you should do a Doppler ultrasound of the legs. How will it help you? Does it help in treatment planning? Yes. This is not just for diagnosis or for MCQs. This is how we really do it in the clinics. How will it affect my treatment plan? Suppose the Doppler ultrasound of the legs comes out to be positive. I have evidence of deep vein thrombosis, right? So suppose I do a Doppler ultrasound and it turns out to be positive. I have evidence of deep vein thrombosis. This evidence is good enough without any further investigations to start treatment for pulmonary embolism. So once you get evidence of thrombosed veins, there is no need to go for any other higher level investigations, right? You simply have to start doing the treatment for pulmonary embolism, right? Please remember, I know you all know that chest X-ray has radiation exposure. Was anybody wondering, ma'am, X-ray karna chahiye tha ya nahi karna chahiye tha? So very important. Remember this always. A pregnant woman coming with symptoms and signs of pulmonary embolism, beta G, chest X-ray has to be done. The radiation exposure is very, very small with a chest X-ray. There is no need to worry at all. And anyways, the patient is 30 weeks pregnant. She is beyond the period of organogenesis, right? So please remember, a pregnant woman coming to you with pulmonary embolism, chest X-ray is a must. Now, How will that change my protocol? So please understand this. If the Doppler ultrasound of the legs is negative, okay? If the Doppler ultrasound of the legs is negative, what do I mean by negative? No evidence of deep vein thrombosis, right? No evidence of deep vein thrombosis. Then what do? Then you have to next go for VQ scan. Okay, ventilation perfusion scan has to be done. If the Doppler ultrasound is negative, that means no evidence of deep vein thrombosis, then the answer has to be go ahead and do a VQ scan. Please remember, this is again different from what you have read in radiology or medicine for non-pregnant patients. In non-pregnant patients, the investigation of choice is CTPA, CT pulmonary angiography, but not here. In pregnant patients, right, if there is no evidence on ultrasound for venous thrombosis, then you have to go and answer VQ scan. When will the answer change to CT scan? Okay, listen to me very carefully. When would the answer change for CT scan? In case the chest X-ray is abnormal. So if the chest X-ray comes out to be having certain findings, here the chest X-ray was normal, but if the chest X-ray has certain findings, right, then we will not do a VQ scan. Why? Because then interpretation of VQ scans becomes difficult or indeterminate. Listen to me carefully. Okay? In case the chest X-ray is normal, then I have said you do a VQ scan if the Doppler is negative. If the chest X-ray is abnormal, okay, then interpretation of VQ scan becomes indeterminate or difficult. So in that case, the answer will then change to CT scan. So if the X-ray is abnormal, then you will have to go for CT scan. When else will you go for CT scan? As I said, if the VQ scan is indeterminate, then yes, you can't help it. You will have to go ahead and do the CT scan. Yes? So is the approach of pulmonary embolism in obstetrics or a pregnant patient clear to you now? It is very different from a suspected pulmonary embolism in a non-pregnant patient. But you needed the medicine part here to identify that it is pulmonary embolism. You needed to know the medicine part here to know what all things do you have as options to go ahead and do for the patient, right? But you needed the obstetric part here to know that there is no role of D-dimer, no role of ABG analysis. Rather, we are going to go for VQ scans. And before that, yes, Doppler ultrasound if you have even the slightest suspicion on the limbs, right? Is this clear to everybody? Yes? CBC is a general investigation. It will never help you here to make a diagnosis. It is a part of the investigations, but it is not the next step, not the next best step. We have to give you 4 options, so some options will be useless. So 2, 3 options are close here. 1 you could rule out any which ways, right? So is the approach clear to all of you? Right, so those were the classic 4 clinical case presentations or clinical vignettes that I had brought specially for you today, not to teach you really obstetrics, but to rather teach you the algorithmic approach for solving clinical vignettes or long stem clinical case scenarios. Yes, so is the approach to solving clinical vignettes clear to you? And if it is clear, all you bachas are going to repeat with me the algorithm. Okay, so we will keep it as Dr. Deepti's algorithm. Yes, so what is the algorithm? Number 1, read the first, which line? Last line, right? So we are going to take a retrograde approach. Okay, so you don't need that kind of time, Paris. Exactly, that is what I'm trying to tell you. If you follow the correct approach, you will not need the time. You just need your content and you need the right approach. That is exactly how you're going to do the time management. Paris, if you do it reverse, if you start the anti-grade approach, you will actually be wasting most of your time. So follow the algorithm, the last line first, then we go to options, okay, to have an idea what the question is all about, even without reading the 7 lines of the MCQ, right? So you don't have to read any lines of the MCQ, read the options, then go to what? Visual, right? So the third part will be if the question has a visual or if the question has a video, see that first, and then go to the stem of the MCQ to find out relevant keywords, right? So the last thing is going to be relevant keywords in the stem. Now, there are 2 secret components to top ranks, okay? So, because you're all bright people, I am sure you're all looking out for top-notch ranks. So, there are 2 secret components to any exam. One is knowledge. So, yes, you have to know your medicine, you have to know your obstetrics, you have to have a good conceptual learning of these subjects, right? Only once you have a good conceptual knowledge, then you need the exam skill. So what I taught you today was an integration of knowledge with exam skills, right? So you have to have knowledge. We can't bypass that, okay? So we have to have good knowledge. We will integrate it with exam skill, which is what I wanted to highlight today for you in the clinical vignette questions. How to do integration, horizontal, vertical, image integration, video integration, right? So ensure that you have that. Very important, as I said, you can never ever, underestimate the value of concept building in a classroom. Like you all are learning with me today. Was it fun? Did you enjoy? I hope I could make it interesting, yet effective and informative. So when you sit live with a teacher, in a classroom when there are other students around as well, the environment is very enriching. Yes, it motivates you to learn more from your peers, from the teacher. It helps you to maintain the level of concentration that you need by different methodologies that the teacher is going to use. I'm going to call out your names. I'm going to appreciate you. I'm going to ask you direct questions. So these things motivate you to go one step further and challenge your limits. So build concepts in the classroom, make a good set of notes, integrate things with the teacher and with the concepts, and then yes, you will have to do multiple revisions. Because you have 19 subjects to do, you will need revision. So don't worry. Don't think that you will know everything in the first reading. It is absolutely fine if you are doing mistakes after your first reading. When you come to a classroom and when you learn with the teacher, 50% of the job is already done, which was concepts. The other 30 to 40% is revision. Yes, so you will get better with every revision. But always remember, Beta Ji, that revision or every successive revision should take lesser and lesser time. So if you have done a good first reading, the next reading should take less time because you will read only, number 1, your volatile aspects. Number 2, areas which you feel you are weak in. So in the second reading, I will start not with the first line, not with the first page, and not with the first paragraph. The second reading will start from areas that I am weak in that subject, from areas which are volatile for me in that subject, which will increase your hit rate in the exam. And gradually, if you make a list out of these topics, gradually you keep cutting them down, your volatile areas become better, your weak areas become better, and the number of topics that you have to read for your third reading will keep reducing. And that's how the time for every revision will also reduce. So don't worry if the first reading you were not able to recall few things. It is absolutely normal. You are normal and you will get better. Have faith, stick to your fight when your hardest hit. Okay? It doesn't matter. Every exam has to be taken as a learning experience. You will come out of it more smarter, brighter, and more intelligent as well. Right? And now I just want to highlight something here because we are experiencing a change in the pattern. Yes, from NEET, we will be moving towards next. I want to give you an idea on what we are looking at. So, when we talk about NEETPG, we had about 300 MCQs and 3.5 hours. That's the time you have, right? So 300 MCQs and 210 minutes. That brings approximately 42 seconds per MCQ. Or in other words, what we tell our students is do 50 MCQs every 30 minutes or 100 MCQs every 1 hour, right? So this is for NEETPG. And this is why some of you had problem this year in the exam when the NEETPG had long MCQs, right? So problem was that these long STEM clinical vignettes needed much more than 42 seconds. They needed approximately 1.5 minutes to read the question, the options, the image. And that's why so many students could not really complete the exam this year in NEETPG. So now when the trend is changing towards clinical case scenarios, analysis-based questions, follow the algorithm that I have taught you to save time. Last line first, options, then image followed by this, and the last is the stem or the body of the question, right? In the next PG exam, it is going to be 120 questions in 180 minutes. So, the government is giving you more time. They're being more liberal. They're giving you approximately 90 seconds per MCQ. But do you think they become liberal with you? No. Why have they increased this time for you? Because more and more MCQs in the next exam or the new pattern NEET, which will be this year, will be more and more concept, application, and integration based, which need more time, right? So that's the kind of things that you will have to sort of face. But as I said, we have to face our fears. Yes, always remember that. एक ही तरीका है डर से आगे जाने का, वो होता है टू मीट योर फियर. तभी कहते हैं ना डर के आगे जीत है. सो यू हैव टू नो कि उस फियर को, जिस चीज से हमें सबसे ज्यादा डर लगता है, वो हमें बार बार करनी चाहिए. इट्स कॉल्ड एज desensitization. Yes, so you expose yourself to these kind of clinical vignettes and do them more and more, and believe me, your fear will go away. Apply the algorithm that I have told you for these questions and you will sail through. So that you can have more and more practice of those clinical vignettes, we have already given you a lot of material. So in the DAMS question bank, you have a whole lot of clinical vignette questions, both as a mixed bag and as subject-wise. So in the mixed bag, we have already uploaded about 1,000 or 2,000 actually clinical vignettes in a set of 500 MCQs, right? So there are 2,000 plus mixed bag clinical vignettes. Apart from this, there are subject-wise clinical vignettes in almost every subject DQB so that you can practice application of your concepts, practice time management. I hope all my bachas are following the DQB promise. One thing that I'm adding to your DQB promise is that try and do those 50 MCQs in 30 minutes, bache, right? So add this one higher level component to the DQB promise. We are in the middle of the August. We have done the DQB promise till now, which was 50 MCQs. I'm adding one more rider to this DQB promise. Do the 50 MCQs in 30 minutes. Time management is going to be vital for your exams. The more you face it, the better you will get at it, right? I hope I could keep the session, high yielding for you. I hope I was able to give you the approach that you need. and as well as teach you some obstetrics, because whenever I get a chance, I don't want to miss out on teaching obstetrics and gynecology. That's something that is very close to my heart. So whenever somebody gives me an opportunity, I always want to include obstetrics and gynecology into it. So I wanted to ensure that I will give some part of the teaching as well here. So I took some very characteristic things where I could teach, but I could give you the extra edge that you need, as well as the approach to clinical vignettes, right? So remember this one last thing in the end. Each clinical vignette simulates a clinical situation. It stimulates or simulates your patient that you will be seeing in an emergency ward, in the OPD, or in your inpatient wards. And when you see these patients, you will have to make an option to treat them. The choices represents the options you have, okay? The choices they give you in the MCQs are the options you have in real life as well. And the choices that you make in your real life, okay, are the choices which will help you progress in the exams and also save life in real life situations in your emergency wards and your OPDs. So it's always about choices that you make good ones, all right? So in the end, I would simply say, lots and lots of good wishes to all of you from my side. Hope you do really, really well in whatever task you take at hand. Go one day by day and just keep doing things irrespective of what the outcome is. Detach yourself from the outcome, but stick to your fight, right? Stick to your journey. And remember, sticking to the journey when your hardest hit is the most important thing. Lots of good wishes and lots of, love from my side. So I hope I made clinical vignettes a little easier for you and they will help you in the exams. Take care. Do write back to me if you look out for any other assistance. Best wishes.